present this plaque to Dr. Vanderlick for putting this wonderful conference together. It does take a lot of time, and it's not paid, of course, so she gets a plaque. So please give her your round of applause. And then if we can go ahead and get started, or again, for another second talk. I don't know why I'm sure glad you get to do it too, right?
Happy to be here. So we're going to switch gears and speak about neurosarcoid. One of the things that I love most about neuroimmunology is that it's so varied, and I think the way to really dig deep into this is to understand the neuropathology. So last session we talked about antibodies that target neurons, and here we're going to be talking about granulomas. And not all brain inflammation is the same, and I think what you'll see is how different kinds of inflammation looks in the brain and how treatments differ. And I hope that at the end of this talk, you'll have a visceral sense, having seen a lot of MRIs and case examples, of what neurosarcoidosis actually looks like, and also a sense of what it doesn't typically look like, and also what the differential is. So my disclosures are the same as last time, and we'll also be discussing off-label treatments. So the objectives here are, part one, I'm going to talk about the pathogenesis and the concept of what sarcoidosis and neurosarcoidosis is. Part two, I'm going to talk about how you diagnose neurosarcoidosis, and part three is how you treat patients. So let's step back for a minute. Sarcoidosis is one of those diagnoses that probably everyone in this room has seen at some point, and one of the reasons that it often feels like people don't have a handle on it is that it's so distributed. It's one of these infiltrative inflammatory disorders that can affect so many different organ systems and so many different parts of the body that even within neurology it tends to get distributed. So if the sarcoidosis affects the spine, it might be seen in spine clinic. If it's the pituitary, it's going to be neuroendocrine. If it's peripheral nerve, it's neuromuscular. So it's rare for one even subspecialty in neurology to get the whole view of what the disease can look like. And then similarly, unlike other systemic inflammatory diseases, which often fall under the umbrella of rheumatology, this disease really primarily gets managed in practice by pulmonology. And that's because sarcoidosis affects the lungs in 80 to 90% of people. And it's really been a pulmonary disease for over a century that way. But more and more, I think, as neurologists, it's going to be important for us to bring knowledge about sarcoidosis and help the interdisciplinary team in understanding whether neurological symptoms are attributable to neurosarcoid when the patient has sarcoidosis, and then also to diagnose sarcoidosis in the nervous system when it's the first presentation. So sarcoidosis is an inflammatory multi-system disorder. So if we step back, it's an autoimmune, an inflammatory disorder, multi-system in the traditional definition, meaning it's not just one organ system. We're going to come back to that, but the classical definition is that it affects the whole body. It's systemic, it's multi-system. So sarcoid-like inflammation in one organ system is sometimes classified as its own entity. In the gut, it's granulomatous inflammation. In the pituitary, sometimes we call it granulomatous hypophysitis. And it's not always clear that any non-infectious focal granulomatous inflammation, when it's not within the full spectrum of a systemic disease, whether that's the same entity of sarcoidosis, although treatment may behave similarly. And its calling card is that it's characterized by non-necrotizing granulomatous inflammation. So we're going to talk all about that. Sarcoidosis has a very strong genetic basis. And what I hope to convince you of over the next couple minutes is that it really is an autoimmune disease. When I first got interested in sarcoidosis, my chair kept pushing me, saying, "Are you sure it's not an infection? We just haven't found the infection." And if you look at textbooks of internal medicine, it's interesting to actually see where they put the chapter on sarcoidosis. Do they put it with rheumatology, with other autoimmune diseases? Do they put it with infections, or do they put it in the diseases of unknown etiology? And it's changed over the years, but I think that more and more the evidence is converging that this is an autoimmune disorder. These are the genetics of sarcoidosis. So it's 80 times more common in terms of the odds of getting it if a monozygotic twin has sarcoidosis for the other twin to get it. 7 times more common if it's a dizygotic twin, 3 to 5 times if it's a sibling. This is very similar to the kinds of twin maps we would see in multiple sclerosis or in rheumatoid arthritis or any complex genetic disorder of autoimmunity. Every gene to date that's been discovered in sarcoidosis using genome-wide association studies is currently involved in inflammation. The challenge is that when you look at different populations, it's sometimes hard to compare a GWAS, a gene-wide association study in a European population in Scandinavia, to one in Japan. And it's been very hard to replicate this around the world. But every gene to date that has been identified is involved in the immune system. There are also a few phenotypes that are probably genetic spin-offs of sarcoidosis proper. In Scandinavia, a classic one that you may have seen is called Lofgren syndrome, and that's an acute presentation where you have hilar lymphadenopathy, so the sarcoid involved in the lungs, usually subclinical, erythema nodosum, this inflammation usually over the shins of the fat tissue there, and an arthritis. And these patients tend to have a very good prognosis. They usually just get better at 2 years, even without treatment. And there's certain HLA associations with Lofgren's. The other classic eponym is Hereford syndrome, also known as uveoparotid fever. I think that's an easier way to remember it. So it can cause uveitis and then parotid gland swelling, which can also, of course, affect the facial nerve. So that's how we might see that. And then pediatric, very early sarcoidosis, so under age 4, where you get granulomatous arthritis, uveitis, and dermatitis, has its own genetic mutation, NOD2, basically it's its own standalone immune dysregulatory syndrome. And NOD2 is not seen in adults with sarcoidosis. So more and more we're actually being able to piece out some of these outlying phenotypes. But at the end of the day, we're left with a complex genetic inheritance of an autoimmune flavor with a lot of the same HLA phenotypes for adult sarcoidosis that we see in MS or lupus or rheumatoid arthritis. In terms of the epidemiology, the prevalence varies depending on group, but it's not rare. It's actually quite common. In African Americans, it's 35 to 71 per 100,000 in both the southern United States and especially from excellent papers coming out of the Detroit area. It's 3 times more common in terms of an age-adjusted incidence in African Americans in the US, and there's a similar ratio in South Africa. In terms of neurosarcoidosis, it's much harder to get numbers, but the incidence is estimated to be about 1 per 100,000, which again is on the order of what we might see for myasthenia gravis or some of these other disorders that we don't consider that rare in neurology. It's actually probably as common or more common than neuromyelitis optica, for example. There was a large NIH-funded case control study called the ACCESS study to look at what causes sarcoidosis, because there are a lot of environmental factors that have been proposed, and unfortunately nothing was identified as causative. That said, there's some very intriguing clues. After the 9/11 attacks, first responders at the World Trade Center had an increase in sarcoid-like granulomatous inflammation of the lungs that on neuropathology looked identical to sarcoidosis. It wasn't a multi-system disorder as classically described, but on lung pathology it looked nearly identical, suggesting that there was something in the air that may have caused sarcoid-like inflammation in genetically susceptible individuals. There's other associations reported in the South with wood-burning stoves, for example. A lot of this remains to be elucidated. This is the same story that we're trying to figure out in multiple sclerosis, where you have a genetic susceptibility and then a very strong environmental component in terms of tipping people over the edge to actually get autoimmunity. The other question is whether there could be an infectious trigger. And why? Because the classic explanation of a granuloma is that it's a response to an infection. There have been many postulated agents over the years, and it's one of these literatures where it gets excited and then gets disproven or not replicated, excited, disproven. And really none of them have panned out. Some of the interesting things that have panned out are that people with sarcoidosis have T cells that are antigenically primed to mycobacterial proteins. So they don't have an active mycobacterial infection by definition, or else we wouldn't call that sarcoid, we'd call that TB. But their T cells are antigenically responsive to specific proteins of TB. The other thing is that pulmonary sarcoidosis and TB have gene expression profiles that are quite similar, and much more similar than if you looked at a profile in lupus, for example, or even if you looked at hypersensitivity pneumonitis, another granulomatous lung disease. So one way of looking at this is it's as if it's an autoimmune response, as if you're fighting a mycobacterial infection, but it's the autoimmune variation. Now, they're not identical, or else they'd be the same thing, and the whole gene expression experiment was conducted to distinguish them, to come up with a test that could distinguish between TB and sarcoidosis. But it's remarkable how similar they are compared to other autoimmune and even other granulomatous diseases. And there's one study that's been coming out of a group at Vanderbilt based on the idea that maybe there is just some infectious agent that we haven't identified where they treat with this regimen of antibiotics. And they've shown in open label studies that chronic lung and skin sarcoidosis get better, but it's not clear, at least to me, whether that's antimicrobial versus anti-inflammatory effects. So it's still an active area investigation in sarcoidosis. We applied our pipeline for infection in cases of neurosarcoidosis, and we included 9 subjects with chronic meningitis from probable or definite neurosarcoidosis. Some of these were quite sick patients, VP shunt, and we have not yet found an infection, including mycobacteria, in the CSS of our sarcoidosis patients. And we've been looking hard to try to find that undiagnosed infection. So I really think that the evidence is converging that this is an autoimmune disease, and I think that that's really the standard now in the pulmonology and rheumatology worlds too. That said, I think it's important for us to distinguish between sarcoidosis and sarcoid-like reactions. Sarcoidosis is classically defined as a multi-organ or a multi-system disease. And if you look at any peer-reviewed paper on sarcoidosis, everyone usually starts with that same line, a multi-organ system disease or a multi-system disease of unclear cause. So what do we do with the roughly 1/3 of cases in neurology that are just brain-specific sarcoidosis, where we can't find sarcoidosis outside of the nervous system? It was usually said that that was rare, and I still sometimes see consults written where isolated neurosarcoidosis is, quote, exceedingly rare. And I'll show you some data later, but in our experience, it's not that rare. It's about 1/3 of our patients with biopsy-confirmed neurosarcoidosis don't have evidence of sarcoidosis elsewhere. It's not that uncommon. But the question is whether that's sarcoidosis proper or whether they have more of an organ-specific sarcoidosis, maybe a form FRUST or just some neurospecific form of this that's distinct from classic sarcoidosis. And the reason I think this matters is that there's no one cookbook, no one algorithm to treat sarcoidosis. You have to treat the organ system involvement. And I'm not sure that these isolated neurosarcoid presentations necessarily follow the same rules that we learn from how you treat sarcoidosis in the lung or the skin or elsewhere. So I think that this is an active area of thinking that we need to do in neurology. So let's start with the pathology. The granuloma is the hallmark of sarcoidosis. So every MRI I'm going to show you comes from our research program and my patients. And what we see here is that this is a patient of mine with a chronic meningitis who, as part of the workup for her chronic meningitis, was found to have hilar and mediastinal lymphadenopathy, biopsy confirmed, classic pulmonary sarcoidosis. There was no evidence of fungus or mycobacteria. We did extensive infectious studies to make sure it wasn't an infectious meningitis, didn't find it, looked for malignancy, felt comfortable saying she has subclinical pulmonary sarcoidosis. She has a meningitis that's consistent with neurosarcoidosis. She has neurosarcoidosis. She didn't respond well initially to therapy, and it just kept worsening and worsening, and so I made the decision to go after and biopsy the meninges and brain just to make sure we weren't missing anything before escalating again. And what we see here is that she has a basilar meningitis type picture with multifocal enhancement around the brainstem, and you can see some nodules. The neurosurgeon chose that one to go after. And what you see on neuropathology, this is an H&E stain of the meninges, is a granuloma. So what is a granuloma? It's so basically a granuloma is a ball of macrophages. So it's an organized collection of monocytes and macrophages, these mononuclear cells, and they come in two different varieties, either well-formed or poorly formed. So this is a well-formed compact granuloma. Well-formed means that I could literally get a scissors out and cut out granuloma from the other tissue. I can draw a border. In TB, it's hazy and you can't really draw a border. The granulomas are sort of leaking everywhere, and they're not these well-formed compact balls of macrophages. The other thing we see here is that there's no necrosis in the middle of this ball of macrophages. So this is a non-necrotizing, well-formed granuloma. Sometimes we call it non-caseating. Caseous means cheese-like. Pathologists like to describe everything as food. It's really just synonymous with non-necrotizing. But that's what we mean, non-caseating, non-necrotizing. Infectious granulomas, classically TB, fungus, some viruses, but especially TB and fungus, are poorly formed and necrotizing. Sarcoidosis, classically, is well-formed or compact and non-necrotizing. Now, in real clinical practice, if you take a large enough sample, especially a very aggressive sarcoidosis in the brain, you may find rare necrotizing granulomas, and you have to be on high alert for that infection. But having a couple necrotizing granulomas doesn't always dissuade us from calling it sarcoidosis, and there's a literature on this, but it makes us feel uncomfortable. But I've had patients who have that who respond well to immune suppression. But it should not be overwhelmingly necrotizing, and any necrosis should make you look very, very hard for an infection or a non-autoimmune cause. The other thing is that sometimes sarcoidosis can be poorly formed, but again, it should be, you need to look harder to make sure you're not missing something else. And so when I look at these pathology slides, those are the things and the buzzwords that we're looking at, and we'll engage with our neuropathologists to make sure we have this right. Sarcoidosis is a pathological diagnosis. And I think it's extremely important for us to rely on pathology to make this diagnosis. Not every steroid-responsive autoimmune process in the brain is sarcoidosis. We need to be careful that we restrict it to this kind of inflammation in the same way that no oncologist would just guess and say, oh, it looks like lymphoma, right? They rely on pathology. And I think we need to do the same. And the reason is that there's a lot of things that can give this brain MRI picture, in addition to infection, lymphomas, histiocytosis, can have this kind of picture. And sometimes, depending on the MRI sequence, you can have other infiltrative diseases, lymphocytic ones, IgG4-related ones, and it's the neuropathology that helps you distinguish them. So this is what a granuloma looks like in the brain. You also sometimes see these multinucleated giant cells. What are these? These are macrophages that fuse their cytoplasms into one master cell. So these macrophages, these monocytes, fuse together and create a giant cell. That's another classic feature. And when you stain for macrophages, CD68, you see it's basically a big ball of macrophages. You will also find some CD3, CD4, CD8 T cells, and you'll find some rare B cells around the edges. And T cells are critical for regulating this, but the actual ball of the macrophage, or of the granuloma, is a macrophage. This is hilar lymphadenopathy on a chest x-ray, and when you biopsy a lymph node, you get the same thing in lymph node tissue. Here you get your big ball of macrophages, your multinucleated giant cell, no necrosis. You like to stain make sure there's no fungus here for GMS, no mycobacteria, and then you say consistent with sarcoidosis, but cannot exclude infection. Clinical correlation is advised. This is one disease where even with brain biopsy, we have trouble sleeping at night, right? Because you're never done. I mean, the pathologist has to always bump it back to the clinician and say, I just can't exclude that there's a sampling error that we missed infection. But at some point, you have to rely on a gold standard, and it's neuropathology with the proper clinical correlation. But it's to show you that these granulomas look similar, but are specific to the organ that they go in. The other thing you'll note about sarcoidosis is that it tends to seed within the nervous system in a particular place and wax and wane over years. This is very, very, very different from MS or NMO or other demyelinating disorders, which are much more stochastic, right? They have relapses, they come and go. Sarcoidosis tends to behave much more like a lymphoma or something else infiltrative, where you seed within the organ system and then wax and wane over years. So this is an example of a patient of mine who actually presented in the late 90s with a progressive optic neuropathy. They didn't digitize the MRIs back then, so I don't have them, but it looked similar. And by 2000, he unfortunately went blind from this process, bilateral no light perception. But it wasn't the end. He kept progressing, started having hypopituitarism and cognitive impairment, and they were trying to find how to diagnose him, and the nasal biopsy was consistent with sarcoidosis. He had some lung involvement, but it wasn't until 2011 that we did a brain biopsy, and he has also skin organ system involvement. This is textbook very aggressive sarcoidosis, and what's striking here is that you can see these enhancing nodules wax and wane over the years, sometimes in association with immune suppression, but never go away. There's very little in neurology that will enhance for 10 years and still have the patient walk around and look okay on clinical exam. I mean, he's not doing okay, right? I mean, it caused him to go blind. He has hypopituitarism, but I mean, he was still able to work and do other activities of daily living, and so his MRI always looked worse than his exam. This is the picture of sarcoidosis, where the MRI is often worse than the patient, and where you wax and wane for sometimes years at a time. It's just very little in neurology that does that. So we'll come back to the treatment side of this story later. So the question is, when we do a brain biopsy, that's a snapshot in time. But you have to imagine that granulomas are actually very dynamic structures, where these big ball of macrophages doesn't just sit there, but is always sort of circulating and moving. And the thought is actually that these macrophages probably recirculate, every 8 hours or so. And they need to probably cross the blood-brain barrier. We think that these macrophages cross from the periphery into the nervous system. The alternative would be that these are microglia, that these are resident brain macrophages. And it's actually very hard to tell in humans immunohistochemically whether you're dealing with a microglial population or a macrophage from the blood. But based on a lot of evidence, I think that these are probably, because they're such perivascular, they're localized so closely to the blood vessels where the macrophages from the periphery would cross. And you also see this enhancement for years and years at a time sometimes, that you probably need this continual blood-brain barrier crossing for granuloma maintenance. And there's some interesting data if you look at zebrafish models of mycobacteria, because understanding this is not just going to help us with sarcoidosis. This could also help us with treating TB or really any infection that relies on granulomas. And what you see here is that these macrophages continually come and go. And interestingly enough, in TB, they can even have virulence, in this Mycobacterial avium, which is a sort of mouse, or a zebrafish model of how others think mycobacterial infections work. These mycobacteria can actually have virulence factors to change signaling with macrophages so that they can hide within granulomas. So it's not actually clear that granulomas are all good or all bad. We think that it's really a complex interplay in infection that way. And if you step back to even TB meningitis, if you don't treat with steroids when you give ripe therapy, people do worse, right? The inflammation is what hurts people early on. And so I think that the more we understand about sarcoidosis and granulomas, the more I think we'll also understand about how to help with the granulomatous damage that happens in other processes like infections of the brain. So one other piece of evidence that's really a historical curiosity, but I think it's interesting, and this is also how you can tell new reviews from old reviews. So if anyone says that Kveim testing is still required, they're copying and pasting from old reviews, because this has been out of practice for a while. But it's an interesting concept. So in the 1960s, the way you diagnosed sarcoidosis, if you weren't going to do a biopsy of the organ system, is that you would inject a homogenate of human sarcoidosis tissue, like a PPD. You would inject it under the skin, wait a month, it makes a bump, and then do a skin biopsy. And if it looked like non-necrotizing granulomas, that was said to have a very high sensitivity and specificity for sarcoidosis. And this was really the gold standard in the literature for years. Why in the world that works, no one knows. I mean, what they literally did was took spleen, or they took lymph nodes of people with sarcoidosis, like put it in the blender, and then would inject it into people. I mean, there's something immunologic there. And that's where the question is there some infection or something in there that does that? The reason this went out of fashion was actually with prion disease in the UK, and then also HIV here. And I mean, I think everyone here would say there's no way I'd have that injected in me now. But this was actually the standard, and no one's ever explained the immunology there. So the diagnostic criteria for neurosarcoidosis has evolved to reflect this change in how we think about this. So a lot of the papers still rely on these 1999 definitions that come out of the UK. And I think it's a very helpful framework, and we build off it, but I think it's important to modernize this. And really what you're doing is getting a level of certainty. How well can I sleep at night that this patient really has sarcoidosis? So definite CNS sarcoidosis or neurosarcoidosis would be that you have pathology evidence from the involved organ system. So if it's central nervous system, you have a brain, meningeal, spinal cord biopsy that shows that, and that you've done exclusion of other causes. Probable means that you have evidence of sarcoidosis elsewhere. Typically, it's either because you biopsied something, or though sometimes people allowed in the past, you could just have an elevated ACE level, or Kveim testing, which we talked about, you're not going to have anymore, or lymphadenopathy. We don't like this much anymore because lymphomas can cause hilar lymphadenopathy. Other infections can cause hilar lymphadenopathy. And ACE is notoriously nonspecific. So in active pulmonary sarcoidosis, the ACE level, which is an enzyme in blood, is elevated in about 60% of patients, but it's not a dichotomous test. You can't distinguish sarcoid from non-sarcoid with reliability. In neurosarcoidosis, I'll show you, our sensitivity is less than 20% from serum or CSF. It's just not that helpful. The other thing is that polymorphisms in the ACE gene can lead to ACE elevations in 5% of the population or more. Kidney disease, liver disease, other infections, all the things that are on our differential diagnosis can also cause ACE elevations. We think that this relates to pulmonary macrophages being active, but it's just non-specific enough. So I get uncomfortable when all I have is an ACE. And I actually don't like sending it as a rule-out test. I'm going to show you that I think you need to look for other things, such as chest imaging, to make the diagnosis. So if all someone has is an elevated ACE, that's not enough to call it sarcoidosis. And then possible would be a typical clinical syndrome. And when you read the literature, it's important to separate biopsy-proven cases from not, because we've all had patients where it was some inflammatory something and seems to respond to steroids, but we don't really know what it is. And I don't think we should call that sarcoid. I think we need to reserve sarcoid for this pathology. It's even a little messier in the pulmonary world, and this informs all the epi about neurosarcoid. So in the ACCESS study, that big NIH case control study I told you about earlier that never found a clear environmental cause, they defined having neurosarcoidosis as you have a positive MRI or an inflammatory CSF in someone that has sarcoidosis, or they have a Bell's palsy, right? I mean, Bell's palsies can happen too. Other unexplained neuropathies. I mean, I think the challenge here is that this is not specific enough from a neurology standpoint. And a lot of the epidemiology about frequency of neurological organ system involvement, the usual claim is that 5 to 15% of people with sarcoidosis will have neurologic involvement, comes from a lot of these definitions. We're reworking some of these, rather than calling it definite, the reworking of the ACCESS guidelines is to call it highly probable. These are synonymous. What you're doing is just trying to put a little humility in there to say, even with a brain biopsy, you shouldn't stop thinking, right? There can be fake outs. But really what you're saying is that there has to be histological evidence of granulomatous inflammation consistent with sarcoid. Probable would be that you have biopsy-confirmed sarcoidosis outside the nervous system and a good clinical syndrome and not explained by something else. And then possible neurosarcoid would be, you think it's sarcoid, but you have no tissue to prove it. I use this in clinical practice, and sometimes we're left with just having possible. I may not want to go after a spinal cord biopsy in someone who's walking well and has a lot to lose. And I can't find sarcoid elsewhere to biopsy, and I think, the best thing to do for the patient is to just stay in the possible world, and as long as they continue to do well, we'll be okay. But I think it's important to flag your notes and to keep coming back and saying there is a certain level of certainty that I'm not sure of. The other thing is that there's a big discussion in the sarcoidosis world about small fiber neuropathy. It's thought to affect about 1/3 of patients with sarcoidosis, but it's not clear at all that that's granulomatous inflammation of the small fiber nerve. I mean, all you see is dropout of those nerves, and it could be more of a systemic toxicity from cytokines, or no one really knows what's causing it. So the working group thought that much like we have a paraneoplastic syndrome, that essentially it's real, it's neurological, but it's not neurosarcoidosis proper. It's not direct infiltration from granulomas and should be seen as its own entity. So let me just speak briefly about peripheral nerve sarcoidosis, and then I'll jump into our central nervous system cases. So the classic presentation is that if it's going to affect the peripheral nervous system, is that often the patients have had sarcoidosis for some time. It's less common that you're going to make the diagnosis of sarcoidosis as a neurologist, although it happens. You can have a polyneuropathy or a polyradiculopathy. Multiple mononeuropathies are rarer, but it's on the list. And the problem is that it can be all over the map, right? We say it's usually axonal, but it can be demyelinating, right? That sort of covers all of electrophysiology. That doesn't help you as much. And so that's why in clinical practice, I think it's important to push for biopsy when the diagnosis is uncertain. And I've had patients with pulmonary sarcoidosis, biopsy confirmed, who then end up having CIDP, for example, or other autoimmune diagnoses. People are allowed to have more than one diagnosis, or they can have diabetic neuropathy, especially if they've been on chronic steroids for a while. And so I think it's important, when it matters, to push for biopsy, or at least to be as sophisticated as possible. Not every neuropathy in a patient with sarcoidosis has to be neurosarcoidosis. If you are going to biopsy, there's a nice paper in Brain that shows that 90% of nerve biopsy cases also have granulomas in muscle when you do both at the same time, which can be helpful if you're concerned about leprosy or other granulomatous causes of nerve problems. Or it might just increase your yield. If you're going to go in there anyway, it gives you another chance at bat to make the diagnosis. So that's typically how we practice when we go after nerve for sarcoidosis. A brief word about small fiber neuropathy. There's a Lancet paper that showed that A remarkable number of patients with sarcoidosis have small fiber neuropathy. They estimate it's around a third. Even a larger number of patients report autonomic changes, and they found that skin biopsy confirmed small fiber dropout. The challenge, though, is that you got to screen for other causes of small fiber neuropathy, but this is a real source of morbidity in people with sarcoidosis. When you go to sarcoidosis patient conferences and talk with people about what matters most to them, it's often relief from these kind of autonomic and pain symptoms. It's not clear that immunosuppression treats the small fiber neuropathy, although some people do claim improvement. Typically, we treat the downstream consequences much like we would any small fiber neuropathy. But I think if you're working up small fiber neuropathy and someone has other symptoms that could be consistent with sarcoidosis, it's certainly on the differential for that. So in our experience with biopsy-confirmed CNS sarcoidosis, and I've restricted this to biopsy-confirmed cases, and of these we have 53, about half are CNS biopsy, half are biopsy of other organ systems, most commonly lung. What we see is that in central nervous system sarcoidosis, so sort of classic CNS neurosarcoidosis, it tends to be a disease that shows up in the 30s to 60s. The median age is around 43 years. So this is a disease that tends to show up in our 30-year-olds to 60-year-olds. It's if it comes in a 90-year-old, I'm much more worried about lymphoma or other explanations for that. It can show up in children. In Denmark, 1% of all sarcoidosis cases are in children. We've seen it a couple times. I haven't included them in this series, but it seems to be much more common in adults, unlike the case with MS, for example, where we recognize onset at younger years. In our experience, it's half female, half men. This is the breakdown by race and ethnicity. Less than 10% of our patients have a family history of sarcoidosis. And I think what's striking is that 90% of our patients did not have known sarcoidosis at the time that the neurologist made the diagnosis. And I think this is consistent with a lot of other centers. Sort of florid neurosarcoid, enhancing brain lesions, chronic meningitis, tends not to show up in people with known sarcoidosis. It tends to be the first presentation, and then we in neurology pick up silent pulmonary sarcoidosis that isn't causing symptoms. And this is different than the kinds of neurological morbidity we might pick up in someone with chronic lung sarcoidosis. So we are usually the first line of defense for making this diagnosis. Enough so that when a patient who has long-standing pulmonary sarcoidosis presents with a meningitis, we need to be on, especially if they're on immunosuppression, we need to be on high alert that it's not VZV meningitis or some other infectious complication. It's very dangerous to presume, oh, sarcoidosis does that. Because I think our epi tells us, no, it tends not to do that. When it presents with florid neurological symptoms, it's most commonly in people where the neurology is driving everything. And then we treat very aggressively, and often the lungs never get a chance to act up. In our experience, about 2/3 of patients have some evidence of pulmonary sarcoidosis or sarcoidosis elsewhere at the time of their neurologic presentation. And when we do an FDG PET, which looks for metabolic activity, which can occur even in normal-sized lymph nodes. So think about this for a minute. You do a chest CT, and there's no hilar lymphadenopathy because they're not big. But you can do an FDG PET, and if you find that they're metabolically active and then go biopsy that, you can still have subclinical pulmonary sarcoidosis that a CT wouldn't pick up. And we picked up sarcoidosis in about 40% of the people that we're doing PETs on when we have a high index of suspicion. You can see that the ACE was useless, 14% sensitivity in our series. When we tap the patients, and I give you the sample sizes of these, we see a low glucose in about 1/3. So this supports the pearl that of the causes of a low CSF glucose, right, the usual ones we would think of would be a bacterial meningitis, mycobacterial fungus, and carcinomatous. Sarcoidosis makes this list in our experience. Whereas MS would never do that. NMO doesn't drop your glucose. Autoimmune encephalitis doesn't drop your glucose. This is one of the few autoimmune causes that can. Rare cases of lupus, myelitis might be others. And then IgG index can be elevated as well. We almost never see eosinophilia in our series, and I see oligoclonal bands in about a quarter of our patients. Some of this, I think, correlates to whether it's a chronic meningitis versus, whether it's a dural presentation. That makes sense, but CSF can be quite helpful. So the observations that I think are practical clinically and interesting scientifically is that it infiltrates within favored CNS sites, it spreads locally, it involves adjacent meninges. So I'm going to show you a bunch of MRIs now, and I want you to appreciate the meningeal propensity of sarcoidosis. It really, really, really likes the meninges. Even in the spinal cord, you'll see that it often has a peel component. In the brain, it often causes a meningitis. And at the end of the day, it causes a clinical syndrome that reflects the underlying neuroanatomy. That's pretty straightforward to us in neurology, but when you're trying to explain what sarcoidosis can do to non-neurologists, it's not helpful to say it can do everything. It can't, but it causes problems wherever it infiltrates. So how do we work up sarcoid? We do a chest CT with contrast. That's probably the most helpful test when you have a high index of suspicion. So when I have a patient with classing relapsing MS, I don't do a chest CT. That's crazy. That's a lot of radiation. That's not what I'm talking about. But if I'm working up a chronic meningitis and I'm not sure what's going on, or if I have a myelitis that's atypical and I want to work this up for sarcoidosis, an ACE is not good enough. You need to do a chest CT. And when that's negative, a whole body FDG PET can be valuable to find those hot nodes that may be normal in size. I also like to survey the entire neuroaxis. You might find areas of enhancement that are much easier to biopsy that can solve your problem, and tissue diagnosis is favored whenever possible. So here's a couple examples here of how this works. So this is a patient of mine who was previously well. She's in her 40s and was in a car accident and had neck pain and had an MRI done for that. So I actually have a pre-MRI. And what you can see is she has a little bit of degenerative changes, but her cord is fine. She went on with her life. 7 months later, she developed a subacute myelopathy. Numb feet, a little weakness, urinary retention. She had an MRI, and what you see here is a longitudinally extensive myelopathy. I define that by a T2 signal change that goes for more than 3 bony levels. When you first see this, if I didn't show you the contrast, you might say, is this NMO? Is this lupus? Go down your differential, and sarcoid's on that list. But what you see here is that the enhancement pattern is very meningeal. There's this peel component. It's almost as if, these are just different cuts through the sagittal sequence, and it's almost as if it's infiltrating from the meninges from the dorsal cord inwards. And as opposed to an enhancement pattern like you would see in MS or neuromyelitis optica, which is more of a ring enhancement or a partial ring enhancement. The anagenic activity here is more meningeal, pushing in from the outside rather than parenchymal itself. And this is why, despite this, she can still walk. It's a much more benign clinical picture than the exact same T2 sequence would look if it were NMO, for example. So the question was this a tumor? And she was referred for the question of a second opinion of, do we do a cervical cord biopsy? Because a chest CT was negative. Did an FDG PET and found that we had a bunch of normal-sized hot nodes. We did a bronch, proved that she had pulmonary sarcoidosis, and said, this is probable neurosarcoidosis. Stop, don't do a cervical cord biopsy. This is the answer. And she's done very well over time on treatment, and I'll show you that later. But that's an example of how you might work up someone for sarcoidosis when that's on your list. And over time, what I can just show you is that it shrunk, and then the enhancement subsequently resolved, and it's been in remission on therapy now for 2+ years, and she's doing very, very, very well. So this abnormal contrast enhancement most typically looks nodular, lobulated. Sometimes it's perivenular. This peel meningeal involvement is classic. And active enhancement is a sign of active neurosarcoidosis. So I find that the contrast enhancement is super helpful. Sometimes you'll see reports of stable, stable, stable. But if someone is stably enhancing, that's bad, right? Stable enhancement means that there's still active inflammation. So I think that we have a wonderful biomarker of active neurosarcoidosis in most patients, which is MRI. And this is something that none of the other organ systems have. You know, it's hard to tell in the lung unless you're doing a PET, which you can't do that often, whether it's scarring versus not. It's sort of like us using walking or visual acuity, right? You can't tell if the damage is from active inflammation or damage already done. So I think that these MRIs are particularly helpful. And an observation that the MRI often appears worse than the patient looks on physical exam. So sarcoidosis looks similar once you start pulling this all together. This is a patient who has this T2 flare hyperintensity here involving the chiasm, and it's this multifocal nodular enhancement involving the chiasm. Biopsy confirmed as non-caseating granulomatous inflammation. Totally different patient here who has pituitary changes and a headache, and you can see this multifocal nodular enhancement. Pituitary experts will look at this and say, this is more than just a typical adenoma. There's a nodular component. I mean, it looks very similar to what we just saw with the optic chiasm earlier. And then when you look carefully in the meninges, there's this perivenular enhancement as well. Here's an extreme but instructive case of a different patient who also has a longitudinally extensive myelitis, has almost like a string of pearls type nodular enhancement all through the upper cord brainstem. Another patient, longitudinally extensive myelitis, you can also see this more meningeal type picture. Another patient, same concept of this very meningeal involved enhancement pattern, who also had little nodules of perivenular enhancement too. The Mayo Clinic group went back and quantitated this and did a very nice job at this, showing that the subpeel enhancement was seen in 2/3 of their neurosarcoidosis spine cases and very few NMO cases in a blinded read. Ring enhancement, like we were talking about, was never seen in neurosarcoidosis. Spinal cord PET, they only did it on a few patients, but it was positive in neurosarcoidosis, and they never saw it positive in NMO. And low CSF glucose was never seen in NMO in their series. It's consistent with our experience. So here's just another example from the clinic to just give you a flavor of how this all comes together. So this is a man in his 30s who had a chronic thoracic myelitis for 12 years. For those of you that care for people with myelitis, that's a really long time to have active myelitis. And it's waxed and waned over the years with this nodular meningeal enhancement and inflammatory exam. It's improved on immune suppression, but he didn't really like being on prednisone, and nothing really worked. He hated being on steroids. We never wanted to biopsy the spinal cord. He could still walk. He just didn't want to do it. So the question, and it wasn't for lack of trying, PET scans, CT scans, and at some point you didn't want to radiate much anymore. This is his CSF profile, pleocytosis, extensive infectious workup. It was negative. Here's that string of pearls type appearance with this sort of leptomeningeal enhancement as well. 8 years later, it's still there. Did another PET scan, and we found a hot node here that the surgeon was able to go in and do a deep lymph node biopsy and show that really he does have sarcoidosis. I was most worried that we were missing a lymphoma here. And that's what he has is pulmonary he had subclinical sarcoidosis with cord sarcoidosis just waxing and waning over 12 years. Relapses, when they occur, tend to be at the site of previous disease activity. It's a waxing and waning. So if someone gets a totally new symptom years later, don't just say, oh, the textbook says neurosarcoidosis can do that. You have to say, where's the infection? So an example of that is I have a patient with a chronic meningitis from bona fide neurosarcoidosis who had biopsy-confirmed pulmonary sarcoidosis has skin sarcoidosis. He has sarcoidosis, and he did very well on immune suppression. He was in remission for 4 years, and then came back with a new, relatively rapidly progressive optic neuropathy. And the imaging didn't show anything new, and we said, oh, sarcoid can cause optic neuropathy, hit with steroids. It had a very careful retinal exam, everything else. It was all cleared by ophtho as just an optic neuropathy. And then unfortunately, it blossomed into what's called progressive outer retinal necrosis. It turns out there was an underlying viral infection of the retina that was then invading the optic nerve. He had a VZV infection as the cause, not a new optic neuritis out of the blue 4 years later. This doesn't behave like MS or NMO that way. So I think that's where this comes in useful. Resolution of abnormal MRI enhancement is usually a good indicator of remission, and CSF can be an important marker of disease activity even when the MRI is negative. Here it just gives you another view of the skull base enhancement and how it sort of waxes and wanes over time here. Here's another patient, that patient with the chiasm involvement, showing that it waxes and waned. She tapered steroids, it comes back again. The relapses are always in the same place. It's as if the darn thing just keeps coming back anagenically whenever you pull away immune suppression. Just an example of CSF, a woman in her early 40s with probable CNS sarcoidosis, so she has chronic meningitis, she has pulmonary sarcoidosis that's biopsy proven. I give you all the data here. And what happened is she's saying, I'm feeling worse, my headache is worse, but the MRI just didn't show any evident abnormality. When we do a TAP, we see that she has a pleocytosis. Her glucose is 36 with a normal serum glucose. She has intrathecal inflammation. This can be a very helpful marker. So don't shy away from LPs even when the MRI is normal in these patients. In terms of treatment, you treat organ system involvement. You don't treat sarcoidosis. So not every patient with sarcoidosis needs to be treated. It's the same thing with lupus. You don't treat lupus. You treat lupus if it's hurting the kidney. You treat lupus if it's causing problems in certain organ systems. It's the same thing with sarcoid. And that said, prominent neurosarcoidosis usually needs to be treated. This is different from how sarcoidosis is usually treated by others. So in pulmonology, it's a much slower moving process. Sarcoidosis is an interstitial lung disease most typically that progresses over years. And so it's the kind of thing, you make a change and then you say, let's repeat a pulmonary function test in 6 months or a year. And then if it's not good after, that time, then we'll maybe start steroids, let's do this. It's a very slow moving process. It's totally different when we're dealing with myelitis or optic neuritis or a meningitis. So we're usually the ones driving immune suppression here because usually the other organ systems aren't needing as much. Usually you have to work as in a multidisciplinary team to make this happen safely. This is how we typically treat neurosarcoidosis. Glucocorticoids are the mainstay. You start high and you do cautious tapers over weeks to several months. As a steroid-sparing agent, we've tended to favor weekly oral methotrexate. There's a strong literature for this in the pulmonary sarcoidosis world. There's even a randomized controlled trial of methotrexate for pulmonary sarcoidosis. Azathioprine would be a good alternative. We use a lot of mycophenolate in neurology, but there's really no literature in pulmonary sarcoidosis for mycophenolate. So it's much less common to be used by rheumatology or pulmonology for that example. And I've seen some patients break through mycophenolate with this disease in our experience. And then TNF-alpha inhibition is particularly helpful as well. So what's the rationale for TNF-alpha inhibition? These are probably drugs that we don't think of much in neurology because they tend to make a lot of our diseases worse, or they cause neurologic problems. So TNF-alpha inhibition actually made EAE, the mouse model of MS, better, but in human trials, it made MS worse. It caused relapses. That said, it seems to work well for sarcoidosis. The logic is that TNF is involved in granuloma maintenance. In mouse models, if you give TNF early, you can prevent granuloma formation. If you give it later, it can make them go away. Granulomas express TNF-alpha, and there's some interesting examples of, even with lung biopsy, showing that you can make granulomas go away pre and post treatment. is a phase 2 randomized controlled trial of Infliximab, which is a TNF-alpha inhibitor, in pulmonary sarcoidosis that showed a modest increase in function in FVC. This is a modest benefit, sort of what you would see with steroids. It hasn't caught on as much because it doesn't seem to be that much superior to steroids for lung disease. In neurology, though, we've observed that it seems to be particularly helpful when patients don't respond to steroids or when they need such high doses of steroids that the toxicity is untenable. Other TNFs have been tried, adalimumab, golimumab, etanercept, and some of them may even harm, but there's really no benefit. There's something about infliximab. Each of these are different antibodies, so they're not identical. There's something about infliximab that seems to work really well for sarcoidosis, especially of the central nervous system and also of the skin and lungs. So it's a chimeric antibody that targets TNF-alpha. It has a bunch of indications, none of which are sarcoid, and there's a bunch of biosimilars coming on the market shortly. The big thing is serious infections and also malignancy. The big infections being all the granulomatous ones, TB, fungal, bacterial. There have been a number of case reports about infliximab over the years. We looked at our experience. We've treated 17 patients to date, a median of 2 years, and we've gotten complete radiologic remission with clinical stabilization in about half, partial improvement with clinical stabilization in 41%, and we had one patient worsen because of a myositis, which has been described as a complication of TNF-alpha. These are the infections we've seen. It's not clear to me that this is any different from what you would see with chronic steroids or chronic oral immune suppression, but we have seen infections in some of our patients. But overall, it tends to be well tolerated. This patient I showed you, who started in the 90s, nothing seemed to touch this for 13 years, was finally able to get remission for the first time in over a decade. Remission meaning it's gone, on TNF-alpha inhibition. Interestingly, at one point, his skin disease came back and then went away again, but his neuro disease hasn't come back. And I have the most recent MRI from last month, and it's still in remission. Another example is this patient who had 6 years of refractory disease that caused bilateral no light perception. He's blind in both eyes, a severe myelopathy. Once it started getting up into the subcortical regions, he started getting cognitive dysfunction as well. Nothing worked, not even mitoxantrone at one point, cytotoxic agents. And then with infliximab, he was able to go into remission for the first time in 6 years and stay in remission. I actually just saw him last week, and he's still in remission and doing well. So the problem is people tend to do well on therapy. How long do you have to treat? We don't know. Typically, we treat for at least 1 to 2 years of remission, meaning it's gone, and then decide whether to pull back. But it has come back in a couple of patients when we've pulled back. Not everyone, but it can, and it tends to do it within 3 to 4 months of stopping, which is sort of what you'd expect from the immunology, and it recurred in the same place where it was active previously, similar to what we were describing. So here's an example where it came back again in the same place. So in summary, neurosarcoidosis tends to seed in the CNS at favored neuroanatomic sites, and it can persist and contrast enhance for months to years at a time. This pattern on MRI of this nodular lobulated enhancement, often with PEEL involvement, is characteristic. CSF can be particularly helpful. Remember, glucose can be low. CSF can be positive, meaning inflammatory, even when MRI is negative. That's, I think, just a sensitivity issue of leptomeningitis on MRI. Relapses tend to occur at sites of previous activity. FDG PET can be particularly helpful. This is PET of the body, not PET of the brain specifically. And aggressive therapy to induce remission is probably best for severe disease. Often it's said, let's try steroids. 50% of people will respond, and then if they don't work, then we'll try something else. But more and more, when the optic nerves are involved, when the spinal cord's involved, if someone's really sick, if they need a VP shunt, why wait 6 months? I'm worried that that's too late. The other thing is that, yes, 80 milligrams of prednisone over the long run might keep the disease at bay, but then glucocorticoids are going to cause major problems. That's not sustainable either. So more and more, once we're sure we have the right diagnosis, if patients want to be aggressive, we're willing to offer more aggressive TNF-alpha therapy up front. I always do steroids first. Some people get away with just steroids or just steroids and methotrexate, but more and more for the severe cases, we're being more aggressive with TNFs, and I know other groups around the country are too. And then caution in saying that any new symptom is neurosarcoid, even when the patient has known sarcoid. I'll stop there and be happy to take any questions. Thank you. Sure.
So you mentioned gallium scan. I don't know what the sensitivity and specificity of it is helpful. We used it in the past for if patient presented with sarcoidosis, but I don't know what the sensitivity and specificity.
So the question is about gallium scan versus PET scan. Gallium scan is very, very good for lung sarcoidosis. FDG PET is better for extrapulmonary sarcoidosis. There's some nice recent nuclear medicine papers showing that. And so in our world, we're really just trying to find any site to biopsy to confirm sarcoidosis. So PET gives you the best chance of finding a lymph node that may not be in the pulmonary system. Gallium is much more where someone has hilar lymphadenopathy or they have what looks like lung sarcoid, and then you're trying to figure out, is it lung sarcoid from some other pulmonary process? So in our practice, and really in the neurosarcoid world, it's less common to order a gallium scan from a neurologic perspective.
I just want to mention something because sarcoidosis, as you mentioned in the beginning, is just like it's affect most Black and African American, and it's not the case. And I think your team work show that like the total number of the patients that are white, who are Hispanic and non-Hispanic was 59, and the 36% only there were Black. So I think in the past it was mentioned that it's more in African American and Black, but now it's not the case. It can be suspected in any patient, even in whites.
I mean, sarcoidosis is thought to really be able to affect anyone. That said, there are certain areas where epidemiologically it seems to be more common. One of them being African Americans being more susceptible, and also Scandinavian populations also seem to have an increased risk. But that doesn't mean it can't occur. It does occur it can occur in really anyone.
Thank you.
Have you found lacrimal gland biopsies to be helpful?
The question is about lacrimal gland. I think the other question would be potentially conjunctival biopsies as well. So there is a literature really exclusively from the Mayo Clinic saying that conjunctival biopsies, even blind conjunctival biopsies, can be particularly helpful in finding granulomas as a way to prove sarcoidosis when you have nowhere else to biopsy. We have not found that to be particularly helpful, but I acknowledge the literature. Thank you very much.